everyone. My name is Alison MacDonald, and I teach the research portion of this course for table clinics for the dental hygiene second year students. The course used to be called, or this used to be called the table clinics, and is now called the Dental Hygiene Research Symposium. Due to COVID, we had to move to an online platform to present. I co-teach this course with Michelle Legier, who is here with me as well. We are very pleased that you are here with us today, and that the students, and to know that the students have worked very hard and in doing their projects. These projects began back in February of this year, and they had to choose a topic, and then they did research on that topic. From there, they developed their methodology to conduct their own research on their topic. From this point, the analysis of their data was done, and from here, I'm going to pass it over to Mr. Legier to explain the work that he has done with the students from here on.
Thank you, Ms. MacDonald. Welcome, everybody. It's my pleasure to be part of this first for Oulton College. And I want to start off by congratulating all the students for the hard work that they've put into this project. The component that I was responsible for was leading the students in developing their skills and abilities in understanding how the research process is undertaken from start to finish, and also dabbling into elements of data analysis to kind of make sense of the results that they found from their different research endeavors. This is something that both Ms. MacDonald and I pride ourselves on at Oulton College, is to give the students in this particular piece of work an authentic research experience, dealing with data from start to finish again, and kind of finding out what different data analysis points can lead to in their own professional practice. We all understand that as professionals in health sciences, we are asked to keep up with the latest innovations in our practice, and this involves understanding different research articles and concepts that come out of such research practice. So hopefully the students will have learned something, and I'm convinced that they'll be able to share what they've come up with in their own personal research projects during the course of the day. So thank you to the students. Thank you, Ms. MacDonald. It's always a pleasure working with you, and I wish everyone watching a fantastic experience. Thank you.
So just for those of you who are dental professionals who are watching this today, and for those of you who will be watching the recording once it has been uploaded to an online platform, you will be able to receive continuing education points for this. And so in order to do that, we're going to ask that you email marketing@oultoncollege.com, and you will receive in return a certificate of attendance that you can submit to your regulatory body for your continuing education points. So I want to complete by saying that we really are appreciative of you watching today, and for those who will be watching the recording. It has been a pleasure as well to work with Mr. Legier over these last number of months again, and I hope that you all enjoy these presentations. Thank you.
Good morning or good afternoon, depending on where you all are this morning. My name is Darcy Repath. I'm the college president responsible for the programming here at the college. It's a pleasure to join you all online today and offer a few words of welcome. So Oulton College is a private career college in Moncton, New Brunswick, started in 1956 to serve the exact purpose that we're here for today, to provide students with quality education that prepares them directly for the workforce. In 2006, we began our dental hygiene program. So we're in our 15th year already. It's hard to believe. The table clinics, as Ms. MacDonald mentioned, have been an important part of our program since the beginning. now called Student Research Symposium. As an important part of this, part of our program, we are so fortunate to have faculty like Mr. Legier and Alison MacDonald, who guide and support the students and consistently are there to help them develop this critical skill as they enter the practice of dental hygiene. Albeit different and a new challenge, we've embraced this opportunity to bring our table clinics, our research symposium, to this online virtual format. This may be one of those new normals that has created some reinvention and some opportunity now for us to share these wonderful projects with you, not just in our hometown of Moncton, but across the province, the provinces, and maybe even Canada. We're pleased to be able to share this with all of you. The students will soon be graduates, and I know whether they will become your colleague, your employee, or your business partner, they will make you proud, they will work hard, they come with integrity, skill, and knowledge. They will be an asset to your team wherever you are. They've worked hard to get here, and they are striving to settle into practice in the next month or so. If you or anyone you know might be interested in speaking with a student about becoming a part of your team, please reach out to us or connect with us on our LinkedIn page for career services. We're so proud of these students and the work they've done. We thank the faculty, the staff, and the advisors who have supported them throughout this journey. It's a pleasure to see you today. We look forward to connecting again soon. Congratulations, students.
Lighting up and sitting pretty, Dental Loops in Practice by dental hygiene students Kaylee MacIsaac and Amanda Sharp with advisor A. Lultu.
Dental hygienists have a physically demanding profession. Repetitive movements and poor ergonomics can contribute to body strain and injury. Interviews were conducted to find the wear of loops among dental hygienists and if they found them beneficial to practice. Our intention is to increase awareness of the benefits of dental loops as they can positively contribute to the body health and function of a dental hygienist.
Our qualitative study investigates how Canadian dental hygienists feel that the use of dental loops is advantageous to their daily practice, and if they contribute the use of these tools to improved ergonomics, posture, and decreased rate of bodily strain and injury. There are a few prior studies revolving around a similar research question, mainly focusing on the highly prevalent musculoskeletal disorder experienced amongst dental hygienists, as well as the experiences and opinions of dental hygienists revolving around dental loops and if they're advantageous towards their ergonomics and overall clinical care. One study in particular that stood out to us and that led us towards furthering our research was one where they took a group of dental hygienists who currently do not practice with dental loops. They then gave these dental hygienists dental loops to incorporate into their daily clinical care routine. After 6 months of practicing with their new loops, they took an online survey to assess the experiences and opinions regarding the new loops. These questions evaluated the ergonomics, clinical skills, overall care, and if they felt that receiving dental loops in dental hygiene school would have been advantageous.
For our methodology, we chose to do a qualitative study. We began by choosing to do semi-directed interviews so that we would have a little bit of leeway for clarification of questions. And we did use one common interviewer just to keep things consistent between our interviews. We started with 2 pilot interviews as a way to evaluate our content because we were looking to make sure our questions flowed nicely and that they were generating adequate responses as opposed to just a very short yes or no. We then went to our 5 formal interviews, which included hygienists of varying ages and graduation dates all across Canada, because we wanted newer hygienists, we wanted older hygienists, we were looking for maybe some that might not have started with loops and added them in afterwards, so that we would get a very nice mix. We then transcribed those interviews and analyzed them using thematic content analysis in order to find the common themes.
The
Common themes experienced amongst our participants were overall posture and ergonomics were improved. To quote respondent 1, definitely, my ergonomics are better when I have my loops. Those who wear dental loops wear them regularly. To quote respondent 2, I use them for every single patient. I'm really dependent on them. The optional light attachment is equally advantageous as the magnification. To quote respondent 5, not only the loops themselves, but having the light on the loops is huge. Highly recommend. Taking care of your body outside of work is very important to help lessen work-related injury. This can include stretching, yoga, and walking. To quote respondent 2, I do yoga 5 times a week and lift weights and run a lot. I'm pretty active, and I think that helps a lot with any strains on the body. Infection control and cross-contamination is a challenge. To quote respondent 4, infection control is something that crosses my mind a lot, especially with all the PPE that we have to wear now.
Many similarities do exist between our study respondents and those of previously conducted studies that we had a look at. So there are positives and negatives based on dental loops involving things more positive, such as improved ergonomics, improved vision, and clinical skill. One of our studies did specify that calculus removal and the caliber of work was also increased. Disadvantages would include infection control, which is now even more based on COVID and those new protocols, and the adjustment period. Musculoskeletal disorders and poor ergonomics are common in the dental profession, and interventions such as clinical ergonomic assessments and physical activities and body therapies outside of work heavily contribute to injury prevention among dental professionals.
Assessment. To assess the opinions of Canadian dental hygienists towards dental loops and how they felt they contribute to ergonomics and the reduction of body strain. Diagnosis. To determine if dental hygienists wear their dental loops regularly and if they benefit their clinical treatment and body posture. Planning. Data collected through interviews on Canadian dental hygienists of various graduation dates. Implementation. Analyze the data to identify common themes amongst our participants. Evaluation. Interviews revealed dental loops are beneficial for ergonomics and the reduction of pain and strain on the body.
In conclusion, the sum of our research has led to both positive and negative feedback surrounding dental loops. Positives include improvement in posture, ergonomics, the light and magnification also increase the clinical vision and decrease body pain and injury. Negatives were found to be the adjustment period, infection control, and the fact that loops are not a fix-all solution for every posture, as there is still room for error in craning necks. Our feedback shows the positive effects of dental loops outweigh the negative effects, as regular wearers found a decrease in body pain and strain and an increase in clinical vision and clinical skill. Limitations of our study included possible rearrangement of the questions just to have a better flow through of conversation. And perhaps a question about introducing loops in school, if there was merit behind that. Most studies that talk about the utilization of dental loops are conducted on dentists only. This leaves a great opportunity for more research to be focused on the dental hygienist specifically. So moving forward, there's definitely opportunity. Thank you so much.
Thank you. Hi, everybody. So Courtney and I today are going to be talking about temporomandibular joint disorder pain and treatments. Our advisor for this was Alison Moore. She has a Bachelor of Arts and she's also an RDH. So I'm going to flip to the next slide and Courtney's going to get us started. Hi, so I will start by talking about giving you a brief overview of why we felt that this topic was important and what brought us to doing more research into this topic. Temporomandibular joint disorder, or TMD, affects roughly 10 to 16% of adults worldwide. And this means it's very prevalent. As dental professionals, it is very important to determine what causes their TMD, how we're able to help them, and be able to point them in the right direction in helping them to seek pain relief. It is very important for us to understand the causes and what treatments best fix those causes, as all the causes have different treatments that can go along with that. We used the research we conducted was to determine the most common causes and also what helped them to alleviate their pain. So for our background, we looked at previous research that was already done on the topic of TMD in regards to pain experienced and how people went about kind of figuring out what was causing that and what the best treatments were for them. So while doing our background research, we found that TMD affects upwards of 36 million adults in the United States alone, and 75% of the population experiences at least one sign, whereas 33% experience at least one symptom. So the non-surgical treatment methods, which would include stuff such as massage therapy, bite plane, etc., made up for about 85 to 90% of treatment approaches for TMD. And they were often best treated with a multidisciplinary approach. So that would be us in conjunction with other healthcare providers, such as the massage therapist, dentist, acupuncturist, in order to have the person experiencing the pain have the best treatment approach. So what we also found while doing our background research is that women were 2 times more likely to experience TMD, and that was linked to hormonal imbalances around childbearing and menopausal age. People suffering from Parkinson's disease were also 4 times more likely to experience TMD, and that's due to the uncontrollable clenching and grinding associated with the disease. And those with arthritis were 2 times more likely as well to experience TMD, and that's linked to the bone porosity and bone density issues that come with arthritis. So overall, our research question that we wanted to investigate a little bit more was, of the various causes of TMD, what seemed to be the most beneficial treatment options for pain relief amongst the general public? In order to gather a little bit more information and to help us answer this research question that Taylor had just said, we used a non-experimental quantitative study in the form of an online survey. We had 40 participants of varying ages and gender, and they all suffered from TMD. The survey consisted of 15 questions which gathered basic information, everywhere from age, gender, how many years they've suffered with TMD, their causes associated, and also what treatments they have tried and what ones they have found they worked best to help alleviate their pain with the TMD. So for the results from our survey, we gathered some basic information, some of which included gender and age. So for gender, we had 40 participants total, and of those 40, 34 were female, which kind of correlated well with the previous background research that we had done, saying that females were 2 times more likely to experience TMD, which kind of also showed with our survey that we had done. And then as for the age of the participants suffering from TMD, the largest age group that responded to our survey that was suffering was the age group of 20 to 29-year-olds, followed by the age group of 50 to 59-year-olds. So that also kind of correlates well with the childbearing ages and the menopausal ages. So if we continue on, there's just a few more results here of the causes associated with TMD of the participants who answered our study. So as you can see, it's quite large, the amount of people who had responded saying that clenching and grinding was the cause behind their TMD. Other issues definitely weren't as relevant, not to say that they're not there, but clenching and grinding definitely was definitely in the lead for the causes. And then as for the most effective treatments of TMD amongst the participants, bite plane was also very common, which we kind of were expecting to see, seeing as the non-surgical treatment methods are most common. It was followed by massage therapy and those who have also not tried any treatment. So we're going to just kind of discuss this a little further. Courtney's going to lead us into this discussion. So we kind of took our results and compared those with previous research. To summarize what we had found from our research, we found TMD was more common in women for those suffering. It was more prevalent of the people aged 20 and older, and also clenching and grinding was the most common cause, with a bite plane being the most common treatment. These results were somewhat consistent with previous studies, and those being that non-surgical treatment methods were more common with helping to alleviate pain associated with TMD, and also that women were at a greater risk than men for developing TMD. Although age and gender can play a role in developing TMD, the mode that we use to promote our survey, that being social media, could have played a role in some of our results obtained, as we are both two young females in our 20s, and this could have played a role with regards to the participants that we obtained in our survey. So moving on to our ADPI, for our assessment and our diagnosis, our main objective was to identify the main causes and the most effective treatments for TMD pain. The planning for this was, as mentioned, we conducted a survey for those diagnosed with TMD to kind of collect data in regards to the pain associated, what causes it, what treatments kind of work best. And then the implementation was to analyze that data so that we were able to put it in the form of graphs to see more visually what the respondents had to say in regards to what treatments had worked best for alleviating the pain. And then evaluation was, of course, to evaluate the data and survey results. So for our conclusion, overall, we were able to kind of determine the following results just based on our study. So TMD was more common in women from what we were able to gather, although the use of social media, as Courtney kind of said, could have played a role in that. TMD was more prevalent in people aged 20 and over, and the non-surgical modes of treatment were most common and successful among the participants. So although the survey findings were consistent with the previous research that we had done, we'll try and collect some background information. We ourselves did not collect enough data to generalize the findings to the general public, and a more extensive research study along with more participants and more funding would be more beneficial to get a more accurate set of data amongst the general public. So overall, what we kind of hope that you take from this presentation is if you or anybody you know are suffering from TMD, talk to a dental professional and discuss treatment options that may work best for you. And here's just a list of our references. So if you're looking to get any more information, then you can just feel free to reach out to one of these sources. So thank you very much for listening and watching to our presentation. If there's any questions, you guys can go ahead and ask them.
Hi, everyone. So my presentation today is how does swimming affect oral conditions in the mouth? Unfortunately, I'm going to be presenting by myself today. So my name is Kaylee Saucier, and my partner's name is Josie Mason. And our advisor is going to be Sophie Theriault. She is a registered dental hygienist, and she is also an instructor here at Oulton College. Let me just see. I can switch that over. Perfect. Okay. So for our introduction, a knowledge synthesis will be used to determine the effects of swimming on the oral cavity and potential long-term adverse effects. Swim Canada has over 5,000 young competitive swimmers registered, and in 2014, 1.1 million children were involved in a swimming program. So we know that this affects a large portion of the population, especially the younger population. Dental erosion can cause problems if moderate to severe, especially in children, again, because that's going to be a progression, especially at an early age. So for example, caries, sensitivity, and self-image issues, especially, again, at that young age. And on average, swimmers train more than athletes in any other sports. So for our background, we want to identify if there is harm to repetitive pool exposure on a person's dental health. Improperly monitored pool water can be acidic, so it can cause severe erosion, dental hypersensitivity from the erosion, and staining of the teeth can happen with prolonged exposure to the water. Oral implications for professional swimmers are much higher when compared to the general public due to the prolonged exposure to the chlorinated water. So basically what we kind of found just in the background alone is that the lower the pH, sorry, the more often you're going to see those negative side effects. Hypochlorous acid is formed when the pool is gas chlorinated. If not balanced with a strong base, this acid will cause the pool water to become acidic and harm to the teeth can happen. So dental hypersensitivity can also affect swimmers, and this is caused by the erosion. And one study by Gertson, he conducted with 56 participants, and we go into more detail with our paper, but 69.6% had sensitivity on the anterior maxillary teeth, and mandibular anterior teeth also had erosion from the swimming. Extrinsic dental staining can also happen from prolonged exposure. And this was actually a pretty important one because there was a study that Moore et al. And more authors wrote about, and they did a study on 21 professional swimmers, and 100% of the participants actually had dental staining. And it's more of a brown shade when it comes to these swimmers. So we are seeing a pattern, and it is also found on the maxillary anterior teeth. So for our methods, we used a knowledge synthesis, so using both quantitative and qualitative data. We used peer-reviewed articles that were published in the last 15 years that targeted professional swimmers of all ages and genders. Our articles that we used were found on EBSCO, Novant, Google Scholar, CDHA, ADHA, ADA, and Swim Canada. Now, these are just some examples of the keywords that we used, but some were swimming, caries, dental hypersensitivity, pH in swimming, erosion, swimming and dental staining, swimmer's mouth, and adverse impacts on competitive swimming. So this is just a nice chart to kind of just show us where we found our articles. So on the left, you can see our databases. We used EBSCO, Novant, Google Scholar, and others like CHA and CDA. So for EBSCO, we found 2 on erosion. Novant, we found 4 on erosion, staining, and sensitivity, and 3 on erosion. Google Scholar, we found 1 on erosion and 3 on staining. And then the others, so the CDHA and the CDA, we found 1 on all of them, so erosion, staining, and sensitivity, and 1 on erosion. So for our results, what we found is that swimming causes a pattern of oral conditions dependent on the time spent in the chlorinated water. So if you're just a casual swimmer and you're not in the water too often, you're not going to really see these effects. These are really for people who are spending a lot of time in the water. So for example, your professional swimmers, they're going to be in the water several hours a day, several days a week. So they're the ones that are being exposed to the water the most. So things that we light just turned off on me, but things that we found were erosion, chalky white rough areas, fractured crowns, attrition, fraction-like defects, stain, tenacious calculation formation, and gritty and grossly uneven surfaces, and of course, sensitivity. And most of these do cause sensitivity, so it definitely makes sense. So for our ADPI, our assessment was to determine if there are adverse impacts to prolonged swimming. Our diagnosis was to identify factors that cause adverse impacts to oral health from swimming. Planning is to research already documented cases and studies to determine if there are dental health implications to swimming. We want to compile all of the peer-reviewed articles to determine if there is an oral health risk to long periods of swimming. Implementation is to analyze all the data found and organize it based on the type of adverse impact swimming caused and make conclusions based off the results. And our evaluation is to share the information found with other dental professionals, competitive swimmers, and guardians of younger swimmers to help educate on the risk factors of swimming in poorly maintained pool water. Because not a lot of people are aware that swimming can actually cause the effects. So to kind of conclude our findings, erosion, sensitivity, and staining can all occur from prolonged exposure to poorly maintained pool water. So we found that maintained pool water, there wasn't really a huge risk to these side effects, but a pool that isn't really maintained properly, and obviously uses chlorinated gas, that is the one that we really found a lot of side effects. And more research needs to be done to educate the swimmers, their guardians, and dental professionals, because not many people are really aware of this situation. Some future research questions that we could include is there a knowledge deficit among swimmers, their coaches, their guardians, and or dental professionals. Is there a way that this can be prevented? Education to pool staff, coaches, swimmers, and their parents. How could we do that? Maybe a better monitoring system for the pH of the pools, and maybe stricter regulations for pools to follow to avoid pool water conditions. So, and these are just our references that we use. And that is it. So does anyone have any questions at all for me? I hope you guys were able to see everything. No questions? Okay, perfect. So if you guys don't have any questions, thank you so much for listening, and we'll move on to the next one.
All right, good morning, everybody. So Maddie and I have a presentation on effectiveness of flossing and interproximal biofilm removal versus oral irrigation. And our advisor was Erin Hingley. So a little bit of an introduction. Many dental professionals recommend flossing as the gold standard for removing biofilm interproximally from teeth. As studies show, flossing is effective in reducing gingivitis, and other studies indicate that oral irrigation, when used both chairside and routinely at home, have shown great results at reducing interproximal biofilm. So before starting our own clinical trial on these studies, we actually looked into a couple articles to kind of get a background and an idea of what we'd be looking into and what other people and researchers had figured out. So the first article we looked at was the article on home use of interdental cleaning devices in addition to toothbrushing for preventing and controlling periodontal disease and dental caries. And this study showed an overall improvement of decreasing biofilm and inflammation with spool floss when compared to brushing alone. So the Worthington study actually decided that spool flossing had the better results when comparing the two methods. And then in contrast to that, we read into another article on comparison of oral irrigation to floss as an adjunct to toothbrushing, again on the effects of biofilm removal and inflammation reduction. And this Barnes study actually said that oral irrigation, when combined with a manual or sonic toothbrush, had the better improvement when compared to spool flossing. So we had a couple of different opinions, and this led us into our research question of which method of interdental cleaning is the most effective on interproximal biofilm removal, spool flossing, or oral irrigation. All right, so a little bit about our research method. We took a test group of 9 participants, and they were randomly selected. Each participant was instructed to not clean interdentally 1 week prior to the study trial. We used Ranford plaque and Eastman interdental bleeding index. So we recorded those before giving them the adjuncts, and then again 2 weeks after using spool floss on the left side of the mouth, and an oral irrigation via syringe and water on the right side of the mouth. So all the participants were instructed to use a soft manual toothbrush for their brushing routine, and were given the same spool floss and oral irrigation syringe. The mean average was then calculated for each participant for both indices on each halves of the mouth, as well as a group average for both. So at our first appointment, like McKenzie said, we instructed our participants to not clean interdentally for the first week before. So these were our baseline results. So first we looked at the Eastman interdental bleeding index, and we did them by each half of the mouth. So the percent of bleeding areas on the left side of the mouth, quads 2 and 3, ended with a group average of 27.02, while the percent of bleeding areas on the right side of the mouth, quads 1 and 4, had a group average of 34.38%. We then looked at the Ranford plaque index next. Same thing, we did each half of the mouth. So PI score for the left side of the mouth, quads 2 and 3, had a group average of 0.98%. And then the PI score on the right side of the mouth, quads 1 and 4, had a group average of 1.15%. So we took these results so that we could compare them after the 2-week trial to our results after using both adjuncts. So that takes us into our post-clinical trial results. So again, we looked at Eastman interdental bleeding index first, and we did it by half the mouth. So percents of bleeding area on the left side of the mouth, quads 2 and 3, which is the side that we spool flossed, actually had a group average of 9.4% after using the floss for 2 weeks. So that was a big difference compared to the preclinical trial result of 27.02%. So there was a drastic change in that. We then looked at the left side, or sorry, the right side of the mouth, again for Eastman Interdental, and the group average went down to a 22.3%, and that was down from the 34.38% that it was at the preclinical trial. So again, another drop, but not as significant as we've seen with the spool flossing. We then looked at Ranford Plaque Index next, and on the left side of the mouth, which was the side that we spool flossed, had a group average of 0.59%, which was down from the 0.98% we had at the first appointment with our patients. And then the right side of the mouth for PI, which was the side we oral irrigated, had a 0.61% final, which was again down from the 1.15% we had at the first appointment, but not as drastic as we've seen with the spool flossing. So with the data and the stats that we collected, we kind of decided that spool flossing had the better results.
So upon analysis of the data from the plaque index and Eastman Interdental, we determined that flossing had the greatest effect on decreasing bleeding scores and the plaque index score when compared to oral irrigation. So the data collected in the research agreed with the conclusion of Worthington's study that flossing combined with toothbrushing had the better results on decreasing dental biofilm and gingival inflammation. While Barnes' study contraindicated these results, stating that oral irrigation, when combined with toothbrushing, had more of an effect on decreasing dental biofilm and gingival inflammation.
So to organize our study, we used ADPI. So that began with our assessment, and this study aimed to research flossing versus oral irrigation and the overall relationship to biofilm removal and reducing inflammation. Our diagnosis was to determine if oral irrigation or flossing has greater benefit to plaque reduction and decreasing bleeding, therefore also reducing gingival inflammation. The plan was to research past studies and conduct a clinical study to compare oral irrigation to spool flossing. We implemented this by comparing the objective data found from the first appointment to the last appointment after the 2-week clinical trial on the left and the right sides of the mouth. And then we evaluated all of this by concluding that spool flossing, when compared to oral irrigation, showed greater impacts overall on the reduction of biofilm and gingival inflammation.
So in conclusion, while oral irrigation and spool flossing both have great results overall, when it comes to healthy participants with no probing depths greater than 3 millimeters, minimal dental biofilm, spool flossing had the greatest impact on reducing gingival inflammation. It's also important to, when reviewing the results, to consider that our participants were generally healthy. They were dental hygiene students, therefore oral irrigation may have had better results in comparison to patients with the +3 probing depths. Hence the importance of treating and providing tools specifically to patients' needs. All right, and that's everything from us. Thank you.
So good morning, everyone in the listening world. I'm Janelle McPhee, and my partner is Neala Spencer. And today we're going to talk to you about 3 minutes can save a life.
So according to the Canadian Cancer Society, it's predicted that in 2020 that 54,000 people will be diagnosed with oral cancer, and 1,500 of those will die. 3,700 Canadian men will be diagnosed with oral cancer, and of those, 1,050 would die. 1,650 Canadian females will be diagnosed with oral cancer, and of that, 440 would die. Oral cancer starts in the cells of the mouth. It's a cancerous tumor, which is a group of cells that grow and destroy nearby tissues. It metastasizes to other parts of the body, and the #1 place for oral cancer to spread to is the lymph nodes in the neck.
So a little bit of background. A research study looked at the frequency of oral cancer screenings by dental hygienists, and the results indicated that 45.8% always perform oral cancer screenings, and 23.5% perform oral cancer screenings on just the initial visit, and 47.4% perform oral cancer screenings on recall visits. California dental hygienists did a study by using a survey that included 20 images of oral cancer lesions. The results were ranging from 40 to 97%. The conclusion was drawn that a dental hygienist's ability to detect oral cancer can be enhanced by continual education. So for this project today, our research question is, what are the barriers that could be affecting the quality of performing a 3-minute oral cancer screening?
So methodologies. We used a qualitative interview using 6 open-ended questions that was distributed to 11 different dental hygienists in both Nova Scotia and New Brunswick. And these questions related to oral cancer screenings and the practices that they use to take in their own clinical setting.
So for our results, within those 6 questions, we did a comparison. So these are the common themes that we found. So for the first question, frequency of oral cancer screenings performance. So an average, it was at every recare visit. Experience prevalence of oral cancer in clinical settings. It was said that have referred for lesions, but did not turn out to be cancerous. The risk indicators for oral cancer. We all know smoking and alcohol uses are the main ones. Strength of knowledge about oral cancer. They all felt that they had significant knowledge about this topic. Time constraints. As quoted from one of them, hygienists are typically always pressed for time. Intraoral and extraoral assessment procedures. One had said that they start with the extraoral exam, feeling the sternocleidomastoid muscle, then jawline. They retract the lips, check the lips, oral mucosa, check hard palate and soft palate. Have patients say, ah, check tonsils, take the tongue with a 2x2 gauze, check all surfaces and feel the floor of the mouth. Now this slide is the differences from the participants. So again, frequency of oral cancer screening performance. Some had said that they only do it on patients 60 or older unless they have a health alert present. Experience prevalence of oral cancer in clinical settings. 2 of the 11 respondents did find a cancerous lesion. It was removed and the patient is now fine. Risk indicators for oral cancer. The common one was none. Strength of knowledge about oral cancer. One did say, I don't feel I have the ability from school to detect oral cancer from other types of lesions or possibilities. Although we learn about it, seeing and doing it firsthand is very different. Time constraints. Again, they all felt time was the biggest barrier. Intraoral and extraoral assessment procedures. One had said that we also have a dye in our office that is often used to stain the lesions to see if they pick up the stain, in which event that the patient would be sent for a consult with an oral surgeon immediately.
Just the discussion. So our respondents felt they had adequate knowledge to perform oral cancer screenings compared with the research that we done that identified the clinicians felt that they did not have adequate knowledge. So based on this, we said that it would be ideal for our patients and to be able to have proper education by extending our knowledge based on our electives that we would have to take. So, yeah.
So for ADPI, our assessment, to determine what the barriers could be affecting the quality of oral cancer screenings. Diagnosis. The goal is to identify oral cancer screening process, so the frequency and the level of knowledge of that clinician. Planning. Compile questions that present factors that potentially contribute to the quality of oral cancer screenings. Implementation. Analyze the data collected to make those conclusions. And evaluation. Share this information collected with dentists in an attempt to lengthen those appointments times to extend the quality of oral cancer screenings, as oral cancer is such an important thing and needs to be more recognized.
So for our conclusion, the most common similarity between the research found in the study and the research conducted was that time was the biggest barrier. If given more time, it was thought that the quality of oral cancer screenings would be positively impacted. It was concluded that the quality and intricacy of performing oral cancer screenings will be affected negatively related to the identified lack of time for the given appointment. Education knowledge did not reveal to be a strong barrier. However, ongoing education is important and will support the detection of abnormalities.
These are our references, and these are references from pictures. Is there any questions? Awesome. Well, thank you so much for giving us time to show you this presentation. We appreciate it very much.
Thank you.
Have a good day.
So hi, my name is Janie and I'm with my partner Alison, and today we're going to be presenting our tabletop. What are the professionals saying about DIY orthodontics?
So as we are aware, information is easily accessible today, which can be advantages to people that are educated, which means they have more of the information to pursue orthodontic treatment. The general population is unaware of the risks that are associated with do-it-yourself orthodontics, and which in fact there are many oral health concerns in relation to do-it-yourself orthodontics. There are currently many websites and companies that are in business with do-it-yourself orthodontics.
So we found various articles about the topic. They mostly consisted of specialists talking about the concerns with DIY orthodontics, and here are some examples that we found in some of those articles. So some companies claim to give patients the guidance they need along the way to straighten their teeth from home. The second one we found was it is difficult to comprehend how these dental labs can make thorough evaluations and diagnosis of the orthodontic needs of their cyber patient. And then the last one is supervision by a licensed dentist is necessary for all phases of orthodontic treatment.
So the study that we conducted was a qualitative research methodology. This included 4 questions that were asked to the participants. These questions were then transcribed and they collected their thoughts and perceptions. For this study, these participants were chosen from communities within New Brunswick, such as Moncton, St. John, and Hampton area. So then we transcribed these interviews and conducted what we needed to find.
So after reviewing the recorded interviews, we compiled a table with the questions and the common themes from interviewers. So our 4 questions were, what are your thoughts and concerns with DIY orthodontics? Do you ever see patients who have tried DIY orthodontics? Have patients consulted with you in regards to DIY orthodontics? And what have you noticed recently with oral side effects that is more common with patients continuing DIY ortho? So the common themes from the specialists that we gathered were, for the first question, potential case of creating bad occlusion, potential situations creating severe gingival recession or tooth loss, no previous or ongoing dental radiographs, pre-existing bone loss, root resorption, impacted teeth, and erupted teeth. For the second question, every case is special to the patient, with outcomes ranging from satisfactory results to re-going a full orthodontic treatment from a specialist. And our third question, usually patients would question the professionals after completing the DIY care rather than before the treatment. And the fourth question, our common side effects were gingival recession, teeth not moving as they should, treatment not working properly, occlusion, and all of those side effects can potentially create future problems.
So with everything that we collected, the data that was collected initiates that not many people are informed with the oral health factors that are including with DIY orthodontic treatment. So when we questioned these professionals and orthodontists, their main point to get across was that DIY orthodontics could potentially cause future health problems down the road, which does support our research.
So for this process, we used ADPI. So we first assessed by determining the thoughts and opinions of orthodontists on DIY orthodontics. Our diagnosis was that the general public is unaware of the potential complications related to DIY orthodontics. Our next phase was we plan to conduct interviews with orthodontists to determine their thoughts and opinions on DIY orthodontics. And we then implemented that by raising awareness to the general public on the factors of DIY orthodontics. And then lastly, for the evaluation phase, we analyzed the information received from the recording interviews, and then we compared common perceptions.
So to conclude with everything, many of the important steps to achieving that perfect smile is with one, a proper diagnosis from a professional, the proper education that is being told to patients, proper radiographs, and most importantly, an individualized care plan for patients. This is very important whether you want to pursue with orthodontic treatment. So to conclude, because there are no radiographs and no confirmed specialists, there's no intraoral assessments being done, there's no periodontal health that's being concluded. This can make it possible for a non-correct diagnosis, that can be made. So that's that.
And these are our references. So thanks for listening.
Thank you.
Hello. So my name is Rochelle Frenette, and I'm here with my partner, Shannon O'Brien.
Hi.
Hi. And our presentation is on genetics and your oral health, and just kind of discussing how genetics can affect your oral health, what that can consist of, and all those fun things like that.
All right, so what is genetics? So not only does your poor oral hygiene can contribute to your oral health problems, but also genetics plays a contributing factor as well. Genetics are the hereditary blueprints that determine your makeup of the human body, and genetics are passed down through generations after generations, which can influence the oral health during the 4th week of the parental development. Genetics can influence oral diseases, oral cancer, malocclusions, dental caries, and even periodontal disease.
Okay, so for background, so the human body's genetic makeup consists of 23 pairs of chromosomes, one of which is passed down from each parent, as we know. So when we have patients that say, oh, my mom has soft teeth or my dad has soft teeth, that's something we need to take in consideration and kind of connect those dots. The chromosomes contain about thousands of DNA gene sequences. Some of these sequences contain dominant or carrier genes. And then these genes can be inherited from one generation to the next from the American Dental Association. So our research question was, can genetics have an impact on your oral health?
All right, so we all know that dental caries is very common and a lot of people get it throughout their lifespan. And we found that several bacteria microbes tend to be associated with dental caries, including the Streptococcus mutans and the Lactobacillus species that Meg Wall found. He also determined that periodontal disease is inherited as an X-linked dominant trait that is passed down to their offspring. And as we all know, periodontal disease is the destruction of bone around the surrounding teeth. So we also found that for malocclusions, which is like the abnormality of the jaw and mouth. We also found out that such as like cleft lip and cleft palate can be passed down by autosomal dominant, autosomal recessive, or even X-linked traits as well. And then we also found that during our research that oral cancer is due to mutations in the protozoocon gene and mutations in the tumor suppressive gene that Megwell found as well.
So for methods, with this research, we use the rapid review, which is a form of a knowledge synthesis, and that allows us to collect and compare the data from previous studies to evaluate how genetics can play a role in your oral health. So by using this, it allowed us to compare the results and the data from other researchers, other articles, other data, and we're including specifically dental related diseases and excluding more of the general health disorders and diseases, because we're concentrating more on the dental related and how that can affect your oral health and overall health, really. So in this research, we're really just looking for evidence showing relation between the genetics and its impact on your oral health, and what are the possible outcomes for these, how to prevent it, and how to treat it.
All right, for our results, so we did use 3 main databases to try and help collect the most relevant data for our research. So on the left there, you can see our article subjects, and then on the right is the number of articles that reference to the genetics health and your oral health as well that we found. So with genetics and periodontal disease, we found 6 research articles. With genetics and dental caries, we found 5. With genetics and oral cancer, we found 1. And with genetics and malocclusion, we found 1. And then with genetics and oral diseases, we found 13.
So for our results, in an article by Ray in 2019, it explains the genetic epidemiology between the role of genetic factors determining your health and dental caries. Approximately 35 to 55 of caries phenotypic variation in the permanent dentition is attributable to genes. So taking this into consideration, 35 to 55% is a lot, but it's also not considering other factors that can also increase your chance for developing caries. An article by Kalie in 2012, they were able to associate cleft lip and palate with disruption of development and fusion of the facial process by genetic, environmental, or combined factors. So genes such as those encoding transcription factors, growth factors, and adhesion molecules have all been implicated in the etiology of cleft lip and palate. Cleft lip and palate can occur because of environmental combined factors, genetics. It can be something that happens while the mom is pregnant with the baby too. And in the periodontitis and loose teeth combined analysis, there was an evidence for association at a single risk locus, which was recently reported as a risk locus for aggressive periodontitis by Shung in 2019.
All right, for our ADPI, for assessment, we gathered our research and we wanted to determine what genetic factors would influence one's oral health. For diagnosis, we identified which genes could cause the oral problems, just like we discussed with the streptomucose and the lactobacillus for dental caries, just an example. For planning, we gathered our research articles from the 3 main databases that we talked about earlier. And we wanted to make sure we find the relevant ones related to genetics and oral health. For implementation, we analyzed the research findings and made conclusions about the results. And then for our evaluation, we shared the information collected in an attempt to show how one's oral health can actually be influenced by genetic factors as well.
So to conclude, the results from the knowledge synthesis can support the idea that genetics can play a role in oral health. The research indicates that the affected genes can influence perio, oral cancer, dental caries, malocclusion, and other oral diseases. As dental professionals, we are entitled to educate and spread awareness on oral health that includes how genetics play a factor on one's oral health. oral diseases can occur from many other unavoidable determinants that go beyond brushing and flossing abilities. So as dental professionals, we have all the knowledge that we can educate our patients on how genetics can affect your oral health and how to treat those and how to teach them how to do proper cleanings with their teeth and keeping them nice and happy and healthy.
And then these are all our references. Does anyone have any questions? No? Well, thank you very much for listening to us.
Thank you so much.
Hello, everyone. I just want to let you know that this concludes the morning session of our Dental Hygiene Research Symposium. We will resume at 12:30 p.m. for the remainder of the presentations. Look forward to seeing you back. Thank you so much. Hello, everyone. Welcome back. We are about to begin the afternoon session for the presentations. We have 5 presentations this afternoon to do, and so we hope that you enjoy all of them. So I will turn my video off and we'll get started with the first one. Thank you.
All right. So I'm Meaghan Boudreau.
And I'm Bethany Hughes.
And we did a project on how has COVID-19 affected your dental health. So our advisor was Elisa Metcalf. So motivation is one of the most important aspects in good oral hygiene routine. So with COVID-19, people may be lacking motivation due to the lockdowns and everything that was being closed. And so they may be lacking motivation for good oral hygiene and techniques and routines.
So during COVID-19 lockdown, many dental offices were closed and only providing emergency dental services, which was causing regular routine hygiene appointments to be postponed. Many studies involve the effects on mental health during the lockdown, the limitations during the pandemic lockdown at dental office for aerosol generating procedures, as well as geriatric patients who have a higher risk of contracting the disease. Our research question was, does COVID-19 influence a patient's motivation to keep a good oral hygiene routine?
So our methodology, we used a quantitative study. We made a questionnaire that was on SurveyMonkey, and it was distributed throughout social media. It featured 10 questions asking participants about their oral hygiene routine before COVID-19. And then we also asked questions compared to how it changed after COVID-19 and if they noticed any effects.
So here are our results of our survey. The first question was, how often do you brush your teeth? Before COVID, 70% brushed twice a day, 27.50% brushed once a day, and 2.50% brushed once a week. After COVID, 25% of the participants noticed a decrease in their brushing. The second question was, how often do you floss or clean between your teeth? 32.50% floss once a day, and they also floss once every couple of days, 20% floss once a week, and 15% do not floss at all. After COVID, 37.50% of participants noticed a decrease in their flossing. The third question was, during COVID-19, how have your dental appointments been canceled or postponed? Before COVID, 72.50% of appointments have been canceled, and after COVID, 40% of participants have not received a cleaning since COVID-19 began. Our last question we asked was, have you noticed your gums bleeding and an increased sensitivity? Before COVID, 27.50% have gum bleeding and sensitivity before the pandemic began. After COVID, 40% of participants noticed an increase in gum bleeding and sensitivity.
So upon analysis of the questionnaire, it was determined that some people lost motivation during the lockdown and have noticed effects in their oral health. So the articles that we researched discussed how mental health declined during the lockdown and how motivation and other limitations can contribute to patients decreasing their oral hygiene. So the results that we got from our questionnaire do align with these articles.
Next is our ADPI. So our assessment was to determine how COVID-19 has affected a patient's motivation to keep up with their oral hygiene routine.
Our diagnosis was to identify what parts of their oral hygiene routine were affected by loss of motivation and determine if some factors are more commonly affected than others. Planning was to compile factors and organize them into a questionnaire, post this questionnaire online and on multiple different social media websites. Our implementation was to analyze the data and make conclusions about our results that we found. Evaluation was to share the information collected in an attempt to inform dental professionals on the importance of motivation for their patients, also informing them of the need for detailed oral hygiene instructions to further enhance their motivation. So while the COVID-19 lockdown has caused a vast majority of dental offices to postpone regular hygiene dental appointments and only provide dental or emergency dental services, many of the participants have not received a dental cleaning since their appointments were canceled because of COVID. And many of the survey participants also noticed a decrease in their oral hygiene routines since the pandemic. So providing patients with proper education and oral hygiene techniques can help keep them motivated during these stressful times. So we can inform them the risks if they don't keep up with consistent routines and techniques. And yeah, these are our references. And that is the end. Does anybody have any questions? Okay, thank you.
Thank you. Hi, everybody. My name is Molly, and my partner Haley and I did our project on post-operative denture care instructions given by dental professionals, and our advisor was Elisa Metcalf.
All right, to begin, so adverse denture effects are caused by improper denture hygiene. These effects can lead to even worse outcomes such as denture stomatitis. If patients are not given adequate instructions on how to care for their dentures, they may resort to other unreliable sources, such as Google or asking a friend. This topic is relevant to the dental field as it will help show the underlying problems of why patients have denture-related adverse effects.
So when we were researching this topic, multiple studies have been done on denture-wearing individuals and their knowledge on denture care. However, none of these articles compared denture care instructions between dentures and dentists, which was what we wanted to achieve in our study. So we had a couple articles that we reviewed. So Musa from 2020 found that poor denture and oral hygiene, as well as sleeping with dentures, have the highest impact on the development of denture-related stomatitis and candida colonization. And Parasini from 2010 showed that only 60% of denture-wearing individuals had an adequate level of denture cleanliness. So for our research question, we wanted to determine who gives more complete post-operative instructions on denture care, denturists or dentists.
Awesome. So in order for our project, for our methodology, we did a quantitative research paradigm was used. So 43 denture-wearing individuals were surveyed. 16 participants received their denture from a denturist, while 27 received their denture from a dentist. The survey consisted of a series of 10 questions relating to the denture care, and participants were found at Oulton College Dental Clinic, hospital settings, as well as online surveys.
So for our results, we thought that it would be a good idea to summarize everything in a double bar graph because it would show both categories side by side very well, and it would compare them. So for the green bar, it shows participants who receive their dentures from a dentist, and the blue bars show participants who receive their dentures from a denturist. So if you look down on the horizontal axis here, we have our questionnaire questions. So just a couple examples. Do you brush your denture? Do you take your denture out at night? Do you clean the tissues under your denture? And then up on the vertical axis, we have the number of participants who answered correctly to these specific questionnaire questions. So just for one example, for the question, do you soak your denture? 70.4% of participants who received their dentures from a dentist answered correctly to this, and 68.8% of participants who received their dentures from a denturist answered correctly to this specific question. So overall, 66.16% of participants who received their dentures from a dentist, as well as 67% of participants who received their dentures from a denturist, answered correctly to the specific denture care questions on our questionnaire. So these numbers were very, very close, only about 1% off.
All right, so comparing the findings from previous research to the present study, the results were very similar, as Molly just stated previously. So our background was 60% of denture wearing individuals had sufficient knowledge on denture cleanliness. And in this study, we had 66.16% of individuals who received their denture from a dentist, as well as 67% of individuals who received their denture from a denturist had proper knowledge on denture care.
So for our ad pie, for assessment, we wanted to determine whether denturists or dentists give more complete post-operative instructions on denture care. For diagnosis, identify which population has the greatest level of knowledge on the topic of denture care, those who receive their dentures from denturists or those who receive them from dentists. For planning, we wanted to use quantitative research through surveying denture-wearing individuals. For implementation, provide more efficient oral hygiene instruction to denture and partial wearing patients, asking questions to decipher their level of knowledge on denture care, and making sure to do this at every appointment. For evaluation, analyze the data from our survey to determine whether denturists or dentists give more complete post-operative instructions on denture care.
So as shown by the data, denturists give more complete lost the lights, complete post-operative instructions on denture care as compared to dentists, which was very interesting because originally Molly and I had thought it would be the opposite. We suspected that the dentist would give more complete post-operative instructions. However, we were proven wrong.
So it's important for dental professionals to educate all denture-wearing patients on proper denture care routinely. This is extremely important for dental hygienists because they're known as basically the educators in the dental field. So it's important that at every appointment, if you have a denture-wearing patient, to ask them all the questions, ask them if they're doing the right techniques, and making sure to do this at every appointment because they may forget in between, and just not assuming that they already know the correct techniques from the last appointment.
Just to add on to that point that Molly just made, by assuming if a patient comes in and they don't present with anything intraorally that might suspect you to lead that they're not taking their denture out or so forth, don't assume that they are, because just because that they don't have denture stomatitis doesn't mean that they aren't taking them out. It could mean they have improper fitting dentures, or when they sleep, they're not fitting. So just make sure to still ask those questions and figure out if they're following the right steps to care for their denture. All right.
Any questions?
Thanks everybody for watching.
Okay, so good afternoon. My name is Meaghan and my partner's name is Katie. And we did our project on COVID-19 and the effects on wellness of dental hygiene students. And our advisor was Mrs. Bradley. So according to the World Health Organization, wellness is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So with that in mind, how would you perceive your mental health to be since the pandemic began? The focus of our project was to determine how the wellness of dental hygiene students have been impacted due to the ongoing restrictions with COVID. So students are struggling to meet their competencies required to graduate as a result of the delayed graduations, and this also impacts their ability to obtain a job. Dental hygiene students are among those that are most at risk of contracting COVID-19 just because we're in close contact with our clients. So students have also been afraid of contracting the virus or spreading it to their loved ones and families.
So the objective of our research was that we wanted to determine what exactly was the biggest cause of decrease in wellness for students during the COVID-19 pandemic. We noticed from the research that we read that a lot of studies just focused on one element to see if it was affected, but our goal was to look at all of the different factors and compare them to see which ones have the greatest effect on student wellness overall.
So to determine which factors were affecting wellness, we completed a quantitative study in the form of a questionnaire. We involved 177 students in dental hygiene programs across Canada. And the questionnaire consisted of 21 questions to determine the change in wellness since the pandemic began, and also what factors have caused a decrease in wellness.
So for our results, we begin by seeing what was the perceived wellness before and after the beginning of the pandemic. As you can see from our graphs here, prior to the pandemic, over 60% of students would have described their wellness as very good or good. But then after the pandemic began, it decreased to only around 23% saying that they would describe it as excellent or good. So note here that since the pandemic began, there was a significant drop in wellness overall. As for individual categories, we asked a variety of questions and then noted the number of students that selected agree or strongly agree as their response. So we asked if they feel anxious most of the time or anxious about contracting COVID-19, concerned about spreading COVID-19 to friends and family, if separation from friends and family affected their mental well-being, they're concerned about spreading COVID to patients or contracting it from patients, if they felt that not being in the classroom setting has affected the way they study, if they experience higher levels of anxiety due to examinations, they're concerned about not meeting graduation requirements, have changed their future plans due to the COVID-19 pandemic, or concerned about their dexterity skills in clinic due to missed clinic time. And we noticed that the highest level of agree or strongly agree responses came from questions surrounding their family, about spreading it to their family, or being separated from their friends and family having a negative impact on their overall wellness.
As we determined from previous studies, there was a major negative impact on dental hygiene students' wellness due to COVID-19. So in one particular study, Aguas concluded that students feared they would lose their manual dexterity skills due to prolonged closure of dental clinics. So the inability to practice their skills or further establish their skills was a major concern. Another study surveyed 335 dental students and found that 54% reported moderate to severe depression. So again, we noticed that there was a major decrease in wellness and throughout the students that we interviewed as well. Another study found that 93% of dental hygiene students felt their health was at risk, which caused stress and a decline in clinical performance. So again, we come back to that fear of contracting COVID from their patients or spreading it to loved ones, and that they found that it really affected their ability to treat patients.
So for the ADPI that we did during our research, we determined the assessment portion was to assess the change in wellness in dental hygiene students since the beginning of the COVID-19 pandemic. We also want to diagnose and identify which factors influence the decrease in wellness the most. While planning, we plan to conduct a questionnaire with dental hygiene students who have been enrolled in a dental hygiene program since the COVID-19 pandemic began, so since March of last year. For intervention, we want to see if we can implement changes to increase wellness in students based on what they say has decreased their wellness. So if we could see what's causing it, is there any way we could fix it? And then for the evaluation, we have to analyze our data from our survey to determine which factors are the largest decrease to the dental hygiene student wellness. So in conclusion, the data collected from the results of our survey show an overall decrease in dental hygiene student wellness since the pandemic began. However, there have been no longitudinal studies done so far to determine the long-term effects of the pandemic, which could change over time. And currently, a solution is not possible for what we found as the biggest deterrent to wellness, because a lot of it has to do with separation from people in different provinces. And currently, the restrictions just don't account for that, which is unfortunate, but just how it is at the moment. But hopefully over time, there will be a better way to aid in that.
Okay, so that ends our presentation. Was there any questions?
Okay, great. Well, thank you.
Thank you.
Okay, so we did our research presentation on pre-procedural rinses that are being used during COVID-19. So as a little introduction, so this is basically just a little bit about COVID. So COVID is transmitted through aerosols, and dental professionals are actually at a greater risk for contracting the virus than the general public. And so as dental professionals, so we require a greater amount of precaution and PPE that must be worn to reduce the risk of the transmission. And so introducing an antimicrobial rinse prior to any dental treatment is just one of the many ways that we can help to reduce the measures, or reduce the occurrence, sorry. So a pre-procedural rinse, it's a liquid substance that's aimed to destroy or inhibit the growth of microbes that can cause disease in the oral cavity, so such as like gingivitis and periodontitis. And so because of its antimicrobial properties, it's become a standard routine across dental offices throughout the country to be used prior to dental treatment. So the question that we were looking at was how many dental professionals across Canada are actually giving the most effective measures towards reducing the viral load.
All right, so we looked at some common oral rinses that are used today. So the first one was hydrogen peroxide, and that is commonly used as a pre-procedural rinse and helps to prevent and treat periodontitis. In 2020, the CDHA recently stated that a hydrogen peroxide antiseptic rinse had ineffective virucidal results. The next one was chlorhexidine. So chlorhexidine belongs to a class of drugs called antimicrobials. And in dentistry, it is commonly used to reduce plaque and treat periodontal disease. The next one was povidone iodine. So povidone iodine is an antiseptic and is used in dentistry for irrigation. And it's mostly effective against gram-positive, gram-negative, enveloped and non-enveloped viruses. And recently in 2021, there was a randomized control trial where it was observed that a decrease in viral load was sustained at 3 hours and 6 hour time points when using the povidone iodine. So for our methodology, we used a quantitative survey with both open and closed-ended questions using Google Forms, and these are distributed via email and Facebook. And a total of 96 dental hygienists responded from all across Canada. So for our results, we first wanted to know if dental hygienists were using a pre-procedural rinse or not. So out of the 96, 94.8% said they were using one, and only 5.2% weren't using a pre-procedural rinse. And all our results came from New Brunswick, Nova Scotia, PEI, Newfoundland, Ontario, Alberta, Saskatchewan, and Manitoba. The next question we asked was which pre-procedural rinse were they using prior to dental treatment? And around 60 hygienists said they were using a hydrogen peroxide, and around 10 said they were using povidone iodine, and less than 10 said they were using a chlorhexidine.
For our results, it was found by multiple studies that povidone iodine was the most effective pre-procedural oral rinse against the SARS-CoV-2 virus. As mentioned earlier, our research found that 94.8% of dental hygienists across Canada were using a pre-procedural oral rinse prior to dental treatment. We also found that only 10 out of the 96 hygienists surveyed were using povidone iodine. That's approximately 10% using the most effective rinse. Just a sec. The discussion. We surveyed 96 dental hygienists across Canada to see if they were using a pre-procedural oral rinse and what one they chose to use. Many studies led to the conclusion that povidone iodine was the most effective rinse. For our assessment, we knew that chlorhexidine, povidone iodine, and
hydrogen peroxide were being used across Canada as pre-procedural oral rinses during the COVID-19 pandemic. Pre-procedural rinses aim to lower the risk of transmission of the SARS-CoV-2 virus. And especially, we wanted to look at this in dental offices. To plan this out, we surveyed 96 dental hygienists across Canada to determine what pre-procedural rinse they were using and why they chose to use it. The goal was to educate dental professionals on what rinse is the most effective choice. Finally, we analyzed the data to determine what percentage of hygienists were in fact using the most effective rinse. Again, according to our results, most hygienists were using hydrogen peroxide as their pre-procedural oral rinse. We know that the most effective is povidone iodine, and we found approximately 14.5% using that one. Therefore, from our results, we gathered that most hygienists in Canada are not using the oral rinse of choice with the highest efficiency against reducing the SARS-CoV-2 transmission rate. Do we have any questions? All right, thank you for listening to our presentation. Hope you have a great day. All right, hello. So my name is MacKenzie McGivry, and my partner Alison Scott and I, we did our presentation on community water fluoridation, and we did this using a DMFS index, and our advisor for this was Ms. Christine Woolley. So as we know, fluoride is a mineral that we can find naturally within the environment, and this has many benefits on our dentition. So dental caries are one of the most common oral diseases that affect a large amount of the population, and fluoride works to build a crystallized layer over a demineralized area. So demineralization happens when we have acid that forms from bacteria and sugar that we consume in our diet or anything like that, and when this acid occurs, it erodes the enamel surface, so it demineralizes that area, and that's what fluoride can do to build that crystallized layer and remineralize it to affect the caries from progressing or anything. And sometimes if it's in its early stages, it can even prevent it or reverse it, so it can stop it, which is very good. And water fluoridation was labeled as one of the best public health measures put in place in the 20th century. So that's amazing. After extensive research completed in 1950s and 60s, though, a lot of places decided to remove water fluoridation as some people were focusing, they were outweighing the risk versus the benefits, and they don't feel comfortable with it. So starting in 2012, a lot of places across Canada actually decided to remove water fluoridation from the water supply. Okay, so for the prevention of dental caries and to limit any possible risks, the safe concentration of water fluoridation is 0.7 parts per million, and adverse effects can be seen at concentrations greater than 2.0 parts per million. And this is why it's very important if you're living in a community that has well water to get that tested for those amounts. Fluoride can be intaked both by systemic and topical concentration. Systemic meaning it is in your water, and topical meaning that you have fluoride in your toothpaste and mouth rinses, and even professional topical fluorides that you may get at the dental office. Adverse effects of this excessive fluoride intake can be shown to be more critical during periods of 15 to 24 months for males and 20 to 30 months for females. Studies conducted have shown up to a 60% decrease in dental caries with communities that have water fluoridation compared to those who do not. And for our research question based on the water fluoridation topic, it is, has the removal of water fluoridation increased the indices of DMFS in school-age children ages 7 to 15?
So as for our methodology, Oulton College holds a free sealant clinic for kids and those that are assessed and can receive sealant. So they hold this every year. And this year we took the opportunity to use this as our data collection. So we did a non-experimental quantitative study on the sealant clinic participants, and we used a DMFS index. So this is decayed, missing, and filled surfaces throughout the oral cavity. And this was conducted on children ranging from about 7 to 15 years of age. So here we have our results from the DMFS score. So this shows you their total score of decayed, missing, filled surfaces throughout the mouth. So you can see our largest frequency was 89.47, and this was a score between 0 and 5, but you can also see we had one participant that had a score between 35 and 40. So that's quite a big range there.
So where the DMFS focuses on both filled surfaces and missing, we wanted to look at strictly present decay in the mouth. And we actually found that there was a 50-50 split of participants with decayed surfaces to those with not. Alrighty, so a study was conducted in the United States based on roughly 19,000 participants ages 2 to 17, and it resulted in a DMF score of 2.2, and they conducted that there was a significance between the cessation of community water fluoridation and current dental caries in those children. In comparison to the above results, the present study that was conducted had a mean DMFS score of 3.4. The 2004 study took into consideration socioeconomic characteristics of participants, choosing different regions and incomes. Participants from the lower socioeconomic regions in this research portrayed the highest DMF scores. The 2004 study had a greater number of participants. As I said, it was 19,604 participants, and the present study looked at a result based on 38 participants.
All right, so as for our ADPI, our assessment was to assess the need for community water fluoridation. Our diagnosis was to identify the presence of decayed, missing, and filled surfaces of teeth. And our plan was to conduct a quantitative study using a DMFS index on school-age children. Implementation was collect data at the Oulton College Sealant Clinic using a DMFS index on participants that ranged from 7 to 15 years of age. And for our evaluation, we would analyze this data to determine the need for community water fluoridation in relation to our results that we found.
So in conclusion, based on the research that was collected from a quantitative study, in our professional opinion, we believe that there is still a significance between community water fluoridation and caries, meaning that there is a need for community water fluoridation. Water fluoridation benefits every community, especially those in a lower socioeconomic status, which is where the highest results of the current research stood. One limitation in this quantitative study from previous years, the Oulton College Sealant Clinic was based on lower socioeconomic backgrounds. This year, based on the pandemic, we just welcomed anyone that was willing to come. Another limitation to the research was that the current research was only based on 38 participants, whereas the other studies were based on much larger populations.
All right, and here we have our references. So does anybody have any questions? All right, well, thank you very much for watching, everybody.
Hi, my name is Jessica Jardine and my partner's name is Erica Tucker, and we have decided to do our project today on early childhood education students and their knowledge of children's oral health. And our advisor was Mary Peltier, RDH.
So early childhood caries is the most prevalent oral disease in children worldwide. It is critical that caregivers are exposed to accurate education regarding a child's oral health. With this proper education, it can help prevent caries and also help educate children and their caregivers. So when parents and caregivers have this knowledge of oral health, or if they do have the lack of oral health education, This can play a major factor in the potential of developing caries. So our background for our research, when we were researching this topic, it was noted that many questionnaires were used in previous research to determine the level of knowledge in trained early childhood educators. In these articles that we found, some noted a lack of education policies surrounding oral health within the daycare, as well as workers themselves reporting limited knowledge of oral health. The lack of education and knowledge in these daycares contributed to growing prevalence of early childhood caries. Therefore, our research question was, what level of knowledge do early childhood education students have regarding children's oral health? So for our research, the study was to determine the level of education regarding the early childhood caries and the oral health that is being taught in early childhood education programs. A quantitative study was carried out of 26 early childhood education students through an online survey. The survey consisted of questions regarding the importance of oral health in children and basic questions regarding the oral cavity of children. So this was some of our results. So for any prior knowledge that the students had regarding oral health, 14 of them had answered that it's always important, or yes, and 12 of them have answered no, that they didn't have any prior knowledge entering the program. And then within the program, 8 of them said that they had gained knowledge regarding oral health, and then 18 of them said that no, they have not gained any knowledge whatsoever in the program regarding oral health. And then 15 of them said that they were aware of what a cavity was. And then 11 of them said no, they weren't aware of it. And then all of them were aware of what a cavity was. So the exact definition of a cavity, all of them knew exactly what that was. And then for fluoride importance, 11 of them said that it was always important. 10 of them said somewhat important. And then we had a select few that said that it wasn't important. And then also the importance of oral education within the program. 15 of them said that it was important to have oral education. 9 of them said it was somewhat important. And then for just a routine and clinical knowledge, we asked them how important they think a routine is for a child. And 25 of them said it was always important. And then also the importance of a proper routine looks like. So this would be like whether the child is flossing once a day or like a few times a week. 8 of them said that it was important to floss a couple times a week. And then 18 of them said it was important to floss just every day. And then dental visits, 14 of them thought that it was important to have their first dental visit when the first tooth erupted. And then a select few said that it was actually 5 that said it was only important before any teeth erupted, which is the correct answer. And then for cavities formation, they said that 18 of them said that it was due to putting a child down while having a bottle. So when they put them to bed, 18 of them said that that's what can cause caries.
So for our discussion, just over half of the early childhood education students did have a background knowledge of oral health prior to the course, but a majority of them did not as well. And majority of the students found that they did not gain any knowledge either during their program. So we're already kind of seeing where we have people who are in a educating role for children who have no knowledge on the full health of a child and what could be perceived as proper for them. And while many students did believe that proper oral hygiene routine was important, some didn't feel that having that taught to children more early on in their lives isn't important and doesn't play any significant factor. So we're kind of seeing a knowledge deficit there of how they're not getting the whys behind how it is good to brush your teeth. But even those who didn't believe that they had much knowledge of oral health, most of the students did have knowledge on what a proper oral hygiene routine is, what caries are, and what causes them. And for our ADPI, for the assessment, we had assessing the knowledge of early childhood education students in regards to children's oral health. The diagnosis was identifying knowledge deficits that early childhood education students may have. For planning, a survey was conducted on the students at the end of their program. We wanted them to have a little bit more of a knowledge base, and they were on their work terms when they actually completed the surveys. And for implementation, we had educate early childhood educators on the importance of enforcing a proper oral hygiene routine in children. And for an evaluation, it was to determine if there is an association between the knowledge deficit and early childhood caries. So in conclusion, based on the results of our survey, it can be concluded that there are a variety of knowledge regarding proper oral hygiene, caries, and caries prevention, but that deficit does lie on why it's important that children should know this early on in age and why it should always be implemented as something that is important for them. And here we just have our references. Is there any questions from anyone? Well, thank you all very, very much.
Thank you. Hello again, everyone. So this concludes our Oulton College Dental Hygiene Research Symposium for this year. As a reminder, please email marketing@oultoncollege.com and include your name and the date of the presentation that you viewed. The email address has been placed in the chat as well for you to view. And when you will receive a certificate of attendance via email back once you have submitted your name and date. On behalf of myself, Mr. Legier, and the students, the graduating dental hygiene students, we want to thank you for participating today. We hope you have enjoyed the presentations, and we look forward to what next year holds for this class as well. Enjoy the rest of your day. Take care.